All right, so let's get started. Our goal for the session today is that by the end, you'll be able to define the terms milestone and untrustable professional activity. You'll be able to describe the application of these concepts, and specifically within the framework of competence by design. You'll be able to describe the application of these concepts and how you'll be using them within your residency program, and hopefully will also help you identify some next steps in the use of your milestones and EPAs. I will just focus you on the fact that we are talking about the use within residency training today, recognizing that competence by design is across the entire continuum from residency through to retirement, but we're going to just focus on training programs today. And before we get in to our main topic, I just need to provide you with a little bit of context and background. We're talking about competency-based medical education and how we are moving within specialty and subspecialty training to a competency-based model. And I'll just remind you that this is a model that really aims to prepare physicians for practice in an outcomes-based sort of way. And by that, what we mean is that we start off by looking at what patients and what society needs from physicians, and based on the outcome that's desired, we design training programs and continuing professional programs to meet those needs. Those, however, are also based on the needs of the learner. It also allows for more flexibility and accountability during learning and training. And it really gets us to focus on achieving the skills and the level of performance that we expect of a physician, instead of just focusing on rotations or time that they're spending in training. And another way to look at it is from this article in the Lancet 2010, where if you look at a traditional model of curriculum, we develop our curriculum. From that, we develop educational assessment objectives. We develop assessments, and really, we're just assessing the objectives that we've developed. In a competency-based model, we start by thinking about our health system and the health needs. We develop the outcomes and the competencies that we need from doctors, and then based on those competencies outcomes, we develop assessment strategies that will ensure that our physicians are meeting those competencies and those outcomes. And we also use those outcomes and competencies to develop our curriculum. So it puts the focus, again, more on what's needed from a physician, and less so on just expert opinion on how they should be taught. Competence by design is a very specific adaptation of a competency-based medical education model to the Canadian context. Within the Royal College, we're seeing it as a multi-year transformational change initiative that will bring that model to specialty education. You've heard a lot probably already about CanMed's 2015. We consider that to be a foundational project of competence by design. CanMeds is the framework on which we build our training and continuing professional development educational programs. And the update of CanMeds into the 2015 format helps give us an up-to-date framework from which to work on. It also will help us by providing generic milestones, and I'll talk a bit more about those and how we can use those milestones across the continuum. Another key concept that I want to go over before we dive into milestones and untrustable professional activities is the concept of stages and how they apply to competence by design. Having an understanding of stages helps us see how milestones and EPAs are going to be used. So I'm going to show you this diagram, which again you may have seen before. And this diagram talks about the competence continuum, and I'm going to focus you on the first 4 stages within this continuum because again we're talking about residency training today. As a student leaves medical school and enters residency, we all recognize that they're a little different in that first few weeks or first month as they're transitioning to the specialty or subspecialty. They've been a senior medical student, they're now a very junior resident, and there's a bit of an orientation and an adaptation and even a change in their professional identity as they transition to that role of resident, and specifically as they transition to the role of resident in their discipline. They start to think of themselves differently. They have to get to know a new team, they have to get to know perhaps a new institution, a new way of doing things, and that's a very distinct stage. And there may be very distinct things that you as a program director or as a teacher want them to learn and want them to show you they can do in those very early days so that you can get a sense of their abilities and what you can expect of them. So every resident will go through this type of stage and then move on to the foundations of the discipline. And the foundations of the specialty or subspecialty may be very different from one discipline to another. But they really are the basic set of skills and knowledge on which we're going to build. And coming from an internal medicine background, you know, I can think of the first year or so of internal medicine training where the residents are doing a lot of in-hospital work. They may be doing some off-service rotations, but they're really gathering a skill set that may not be that specific to internal medicine, but gives them an overall breadth of skills to build on. In the core of the discipline, the residents really are performing the basic tasks and functions of the discipline. If you followed these folks around for a day, they would be doing the kinds of things that you would be doing, but at a more supervised level or at a more junior level. And it's anticipated that for most specialties and subspecialties, this really will be the bulk of time in training. The transition to practice phase, though, is again a bit of a new concept for us, but its goal is to be very explicit about the last few weeks or months of training when a resident is really expected to integrate all the knowledge and skills and abilities that they've gained during residency and start to apply those in a very independent and autonomous way, so that when they move into practice at the end of residency, it's a gentle step as opposed to a big jump or leap into independent practice. The other thing that I'll emphasize for you is that if a resident moves from a specialty to a subspecialty, they would start this 4 stages again. So again, coming from a nephrology background, someone that comes to us from internal medicine, in those first few weeks in nephrology, they're transitioning to become a nephrologist. And we may shorten some of these stages in a subspecialty, but the distinct idea that someone will explicitly go through stages throughout their training holds true for both specialties and subspecialties. So I emphasize this for you because the next concepts that we're going to talk about, milestones and EPAs, really reside within these 4 stages. So what is a milestone? Well, a milestone's been defined as an observable marker of an individual's ability across a developmental continuum. So it's someone's ability. It's something that they can do. It's something that you can watch them do. And the idea that it's along a developmental continuum brings the milestone aspects in. This idea that there's a certain stepwise, there's a certain progression of our skills over time. What is an entrustable professional activity or an EPA? It's been described as an essential task of a discipline, something an individual can be trusted to perform independently in a given context. And we'll come back to these again. Focusing first on milestones, in Competence by Design, we'll have a set of generic milestones that are applicable to all specialties and subspecialties, and those have been written within the CanMeds 2015 framework. There are abilities within each of the 7 CanMeds roles, and within that CanMeds 2015 Series 4 framework, they're bound to the stage and the progression of physician development. And by that, I mean that milestones have been written within the stages so that we can look to see what would be expected from the point of view of an ability when someone's at a foundation stage as compared to, say, when someone's in the stage of core stage of a discipline. Here are some examples of that. So if you look at the generic examples here at the medical expert, we've given you examples from two enabling competencies, one that has to do with performing a procedure and one that has to do with implementing a plan. And you can see that we can write these milestones, therefore, both for technical type skills like a procedure, and we can write milestones that demonstrate an progressing level of ability from being able to set up a patient for a procedure, to be able to perform common procedures, to be able to competently perform all the procedures in the discipline. And we can also write milestones for what people sometimes label as cognitive abilities, like coming up with a plan. And again, we can demonstrate that at an earlier stage, we might be coordinating investigations and treatments, and at a later stage, we might actually be the ones that are establishing plans or implementing plans in the full scope of looking after a patient. Now, entrustable professional activities take on a very specific role within the Royal College Competence by Design framework. And that is that they also are linked to a stage. And this perhaps is different from how you've seen entrustable professional activities described or used in the literature or in other jurisdictions. So a Royal College entrustable professional activity is a task in the clinical setting that can be delegated to a resident by their supervisor once sufficient competence has been demonstrated. And again, it's linked to a specific stage in the progression. I'll give you some examples of that. In the real world, an example of a task that we entrust people to do once they've shown us that they're capable of doing it is parallel parking. It requires a number of different abilities. It requires both technical as well as cognitive abilities, and we have to demonstrate to someone that we're capable of doing it before we receive a license to do so. An example from medicine that might be familiar to many of us is the idea of running a code or a cardiac arrest. And again, coming from an internal medicine background, this is something that we routinely entrust junior and senior residents to do. It is a complex task. It is clearly in a clinical setting. It encompasses multiple abilities, both cognitive and technical, as well as leadership skills and team skills. And a key concept within entrustable professional activities is this idea of entrustment. This idea that you as a supervisor, as a teacher, or as a program are making a judgment about delegating a task to an individual because you trust that they will be able to do it in the given context at the right time. So let's stop there and see if you have any questions about what we've discussed so far, recognizing that we'll move next to talk about how we're going to be using EPAs and milestones in your residency training.
So the first question we have, won't there be some milestones that contribute towards many different RC EPAs? If a resident achieves a milestone in one RC EPA, does it mean he or she has achieved it in another?
So that's a good question. It brings in the idea that milestones are related to EPAs that we'll talk about a little bit more later on. And milestones are different abilities that you would integrate to perform within one entrustable professional activity or one task. And you're quite right that there are some milestones that might be used many different times, and you can think about the ability to take a history from someone and have that type of communication skill, which we might use in all sorts of tasks throughout the entire progression of residency training. What's different about that ability is the context that we use it in. What's the complexity of the case? What's the environment that we're using it in? Are there any specific or unique communication challenges with this individual? And so yes, the milestone can be part of many EPAs. You may be able to, as a resident, achieve it in one context, but still struggle in another.
The next question, can a resident pass an EPA even if he or she does not achieve all of the associated milestones?
So we're, again, foreshadowing the idea that we'll be using EPAs as assessments, and we'll talk about that a little bit more. I might defer that question until we go through the next section, Lana. Okay. So we'll move on then. So how will we use milestones and EPAs? Well, when we think about teaching and learning from a residency point of view, we often think about curriculum and assessment, and we can use milestones and EPAs in both of these contexts. So we can think of a curriculum as training individuals to perform certain skills and to have certain abilities at a defined stage of training. And in that way, milestones link to curriculum. We can also think of assessments, and in the competence by design model, we want to make them part of progression of competence. And we want assessments to be meaningful and measurable and to help us track how someone develops their skills over time. And we can think of observations that we might do of tasks that individuals perform, of entrustable professional activities that they perform over time, and start to see how the link can occur between an EPA and an assessment. And I'll just emphasize again that there is a difference, although we often talk about them in the same sentence. The difference is that EPAs are the tasks that have to be accomplished, where the milestones are the abilities of an individual. And clearly they're related. We use abilities to perform tasks. I'll give you a few examples to see if it helps crystallize these concepts. With medical oncology, which is one of our early adopters of competence by design, we've written some entrustable professional activities and milestones. And one of the entrustable professional activities that they wrote for their foundation stage was the idea that their residents would have to provide initial care for urgent and emergent oncologic situations. So that's clearly a task. Some of the milestones that they've written include these that are located primarily within the medical expert role, but the ability to recognize urgent and emergent oncologic issues and they provide some specific contexts around what these issues might be. The ability to select and administer appropriate interventions for these things. But also the ability to identify the limits of their own expertise and when they might need to seek appropriate assistance and supervision. So again, these are discrete abilities. And if we think about back to that model that I showed you early on about how competency-based education works, we can see how milestones and EPAs may link into this model. Well, this idea that if we're starting from competencies and we're starting from outcomes, we need to develop that into a curriculum. We need to break down that complex outcome into the types of things that we need to teach someone to be able to do. And by writing milestones, we become very explicit about the skills and abilities that someone needs to develop and that we need to teach and ensure are present within our curriculum. Likewise, if we go back to those outcomes and we start to think of them as different tasks of the discipline, then we can write specific and trustable professional activities. And because those are observable tasks of the discipline, we can help our teachers focus their assessment around the observation of that, of the performance of that task, and help them provide meaningful feedback to the residents throughout training. So those milestones that medical oncology wrote, you can start to see how they can be integrated within that entrustable professional activity. And those are maybe just 3 milestones within that EPA. That EPA may have more in there because you could imagine that as part of providing initial care, you may also have to work with a team, including nurses and other providers of emergent care. You might have to have good communication skills so you can quickly establish rapport with a patient that is undergoing an emergent issue, elicit information from them, and be able to act quickly on what you hear to come up with a plan. So you can hopefully start to see how milestones integrate into entrustable professional activities. And again, just emphasize that we hope think more of milestones around how they might be used for planning educational design and for teaching around specific activities. With, again, that idea that a novice or a learner in our discipline needs our help in breaking down a task into individual pieces, individual abilities, so that they can really learn all the aspects of the task. It's hard for them to see all the different elements within a task if they're just observing us doing it. They need our help in making that clear for them. And we hope that milestones will help create that very explicit description of the expectations. Whereas EPAs really help us in the clinical setting because they integrate all these milestones into something that's meaningful, that's relevant, that you as a supervisor or a teacher can readily identify that a resident would be doing, that you can observe and you can give feedback on. So some of the benefits we think are that clear link to the clinical activities, something that we often struggle with currently in residency training is how do we make people's clinical work relevant to them? How do we help them learn and how do we assess them in that setting? It helps us identify clearly defined targets and expectations or standards for performance, with the goal being better preparation to serve patients in the community and also the development of our own self-assessment and learning abilities through training so that we can continue to focus on these things throughout practice. So I think we've got an opportunity to maybe stop here and ask some questions. Lana, did you have some there?
Yeah, right now we have 2. So the first one is, so while RC EPAs build to create EPAs, one would think a Canadian EPA for a discipline should be fairly similar to one in the U.S.
Okay. So I'll just provide some context for folks around this question, perhaps. I think this question is getting at the idea that some of the EPAs that we've heard from other jurisdictions in the United States, for example, really are quite large. They're written at the stage of what someone would be able to accomplish at the end of training or would be doing within practice. And the Royal College EPAs, as I've tried to emphasize, are different. They really are focused within a stage. To answer the question of whether they're building up together to create a big EPA, in a sense they are. As we've been writing these EPAs with our 2 early adopter disciplines, otolaryngology, head and neck surgery, as well as medical oncology, we've seen how some of these start to fit together. But our goal really is to write them within the stage and help teachers and residents understand how to focus teaching and assessment within a stage. Some of the challenges of those end of graduation EPAs is that they're quite mammoth in their scope. Royal College EPAs are much more practical and relevant to residents' day-to-day activities.
Okay, next question. How will we address those personal qualities important for physicians but are very hard to put into words?
So what I'm hearing from that question is if we focus on all the little bits Are we missing looking at the whole? And I think that's a very good question, and it's really one of the challenges of something like competency-based education, regardless of whether it's happening in hairdressing or whether it's happening in medicine. How do we make sure we don't lose sight of the whole? So I think the answer to that is looking at all the EPAs at the end and being clear that they do represent the discipline. And there may be a need, an ongoing need still, for some global assessments of performance along the way. We're not focusing specifically on assessments today, but that is one of the aspects that the Royal College is continuing to work through. But clearly, we not only need someone to perform a task, but we need them to be professional. We need them to recognize when to do a task and use their skills appropriately. And these are the more global aspects of performance that we have to ensure maintain part of our assessment approach.
Okay, next question. How do milestones differ from the traditional objective?
Yep. That's a good question. I think part of the way that milestones are different is that they are more clearly linked to a specific progression through training, whereas we haven't always had that with objectives. Currently we have objectives that are written by specialty committees, the objectives of training requirements, which are focusing on what a graduate must be able to do at the end of training. We also have rotation-specific objectives that are linked to a specific training activity. Whereas the milestones may be used in both of those contexts, but they're really specific within that stage. So from a teaching point of view, when I have a junior resident come to my general nephrology clinic, if I know what the milestones are within that stage and which ones link to an outpatient clinic, I can really help target the patients that resident sees, the feedback that I give that resident to focus on the milestones that are relevant for him. And that's something that I think we've had a challenge doing with objectives as they're currently written.
Okay, the final question we have. Can you comment on the difference between stage-specific EPAs versus end-of-training EPAs? Which are more intuitive?
So my bias is going to be that I think stage-specific EPAs are more intuitive because they are more clearly related to the type of activities that residents are already performing. And I think you make these judgments already as teachers and as faculty members. When you're in clinic or when you're on the ward or when you're in the lab signing off on a specimen with someone, you know that already you make judgments and decisions about that individual's abilities. There are patients that I will let residents see, and there are patients that I will go in the room with them. There are times when I will ask a resident to go in and do the entire consult, and there's times when I'll ask them to step out and go in together and do the physical exam. And that's really what we mean by entrustable professional activities. I'm entrusting a resident to do a certain amount of clinical activity autonomously. And that's a judgment I'm making based on the observations I have of their abilities. We're now trying to make that intuitive decision a little bit more explicit. I'm sure there's more questions, and we'll just move on with a few more slides and then come back to more time for questions as well. So I think in those questions we already came up with a few ways that as a teacher you might end up using milestones and EPAs. You might focus on specific clinical activities with residents at different stages, or focus on teaching towards specific milestones within that stage, And you may end up conducting assessments of entrustable professional activities that are linked to your clinical context and your type of practice. And how will we use these milestones within each stage of residency? So this has been touched on a little bit by some of our questions already, but I hope this next set of diagrams will help illustrate it a little bit for you. So if we look at sort of a coned-in view of just the 4 stages of residency from our competence continuum diagram, we can imagine that we have different milestones within each of those stages. And as a teacher or as a program director, there would be clinical activities or formal educational activities that introduce these milestones, help residents hone their abilities or skills around these specific abilities. When it comes time to use these milestones within a clinical setting, we would bundle these milestones together in an entrustable professional activity. And the task of doing that thinking is a task of the specialty committee. So an EPA would integrate multiple milestones. And so that you could think that within each of those stages then, we have a number of entrustable professional activities, and their number is not necessarily illustrated by the diagram, but we would have entrustable professional activities that reside within the 4 stages as well. And so, I'm going to go back a slide again, so that when we're working with residents in the clinical setting, we can focus on the entrustable professional activities within that stage and use those as an opportunities for assessment. And if a trainee successfully completes an entrustable professional activity, you might be asked as a supervisor to document that. The resident would then have that in their portfolio of things that they've accomplished, and they could move on and focus on the next set of skills, the next tasks that they want to master in their progression in training. Alternatively, if you observe a resident and you find that they're not able to complete that task, or they complete it but they don't do it as well as you'd like them to. One of the benefits of the link between EPAs and milestones is then, as a supervisor, you can, in a sense, unpack the EPA. You can open it up and start to examine the various abilities that have been linked to that clinical task. You can use that extra information to review the resident's performance, and perhaps you can identify where they were struggling. What was the aspect of that task that led you to feel they didn't do it well enough? And that helps you provide targeted feedback. Or you may find that they could do the individual tasks, but they were struggling with the context. There was something different about that patient that made it difficult for them, and that helps you have a different conversation with the resident as well. And over time, the way that we anticipate these will be used within a program is that residents will have observations that help document that entrustable professional activities have been performed well. Those observations will be documented as an assessment. And when a resident has collected assessments around an EPA, that will sit within their portfolio with their program director. And at some point, they will have a summative decision made by a committee of the residency training program that they have, in fact, accomplished all the entrustable professional activities in that stage. Perhaps that global aspect that we talked about before, that they are performing overall well in their residency, not only in performing discrete activities, but in what you would expect from a resident at that stage. And they would be able to progress from one stage to another. And then they'd start working on the activities within the foundation stage, and so on. So in that way, we can start to link milestones and EPAs to the progression of competence and the progression of a resident through a training program. So let's stop there because I think we had some questions already about how EPAs will be used in training.
So the first question, if EPAs bundle multiple enabling competencies in clinical contexts, does the Royal College anticipate EPAs to be assessed holistically, and how many observations would be required to sign off on an EPA?
Yeah. So that's something that we would be working on with the specialty committees to decide. And it may differ from one discipline to another, and it may also differ depending on the size of the or complexity of that EPA. So let me give you an example. We talked about that entrustable professional activity for medical oncology that had to do with recognizing and providing initial care for medical oncology emergencies. They had identified about 5 different types of medical oncology emergency. And some of the skills and abilities that one would use would be very much the same from one of those to another. So, for example, eliciting a history very quickly from someone who's very ill, prioritizing, responding appropriately, working well with the team, those might be milestones that would be similar regardless of what type of emergency someone arrived in. On the other hand, providing an appropriate treatment and intervention for someone presenting with hypercalcemia is a different skill set than providing appropriate treatment for someone who's presenting, say, with febrile neutropenia. So medical oncology may decide that for that entrustable professional activity, they may want to have 4 or 5 or 6 assessments of that EPA, capturing the different contexts in which it's performed.
So the next one is more of a comment. Stage-specific EPA are just a continuum of the overall EPA.
So I think, again, that's a question regarding the link between the Royal College approach to entrustable professional activities and the larger end-of-training entrustable professional activities that we've seen from some other jurisdictions. And I think the answer to that comment is sort of. Because some entrustable professional activities do build and become more complex over time. So we use the example of some milestones related to procedural skills and how there might be some common procedures that you perform early on and then a more fulsome list of procedures that you're able to perform by the end of training. But some EPAs actually only do not grow further. And I'll use the example of the EPA of running a code. I don't think you ever get better at running a code than you do in the 2nd or 3rd year of internal medicine. And because that's when they do it all the time. They're on call at night, they're carrying that code pager. And as an internist, I really think that's the peak of your ability to do that. So that entrustable professional activity may reside within the foundation or the core stage of internal medicine, and it may not build into anything more at the transition to practice or end of training level. They've already accomplished it to the fullest mastery earlier on in training.
Okay, next question. Should the milestones and EPAs replace rotation-specific objectives and rotation-specific evaluations?
That's a great question, and I think really shows a good understanding of how these will be potentially used in training. Because I think the answer is yes, they could. As you think about any given specific clinical experience that you want your residents to have, it may actually be clearer for them to describe the sorts of EPAs or tasks that you want them to be able to accomplish by the end of that period of training. So in that way, working towards those EPAs becomes, in a sense, the objectives for that rotation. It's their expectation at the end of that rotation. And the milestones that are linked to those entrustable professional activities would be the specific abilities that they need to acquire. Likewise, doing the assessment of those EPAs may be the assessment that you want of that clinical activity. Did that clinical activity achieve the outcomes that I wanted it to? I wanted, as a program director, the resident to be able to accomplish these EPAs in that clinical activity. So in that way, they may replace an ITER, they may replace the rotation-specific objectives. On the other hand, as a program director, you may also want to have some global assessment of their performance during that rotation. And it may not be the same as the ITER that you're completing now, but there may also be some of that more comprehensive, longitudinal information that you want to capture about a resident's performance.
Okay, next question. I have been alpha testing Milestone EPA. One problem is how to appropriately obtain assessments. Do you feel that we have to make some mandatory?
So I guess a bit of a question that is how and why it's difficult to obtain those assessments. So I'll have to make a bit of a guess as to why you're having difficulty. But often what we hear is that assessments are hard to do. Assessments take a lot of time. Teachers don't have a lot of time. And how do we get them to focus down on the aspects that we really want them to capture? In terms of making them mandatory, the intent of the Royal College is to have entrustable professional activities that demonstrate that progression of competence. So these will be required. A resident will have to track, and a program will have to demonstrate that a resident is achieving the entrustable professional activities of the discipline in order for them to progress through training and ultimately to achieve certification. And the other part of that answer is that I think we can do a better job at supporting our faculty in completing their assessments. I think if we're clear to our faculty that we're asking them to focus on a specific task rather than the sort of more global assessments that we're doing now, that it's an activity that hopefully only takes them a few minutes rather than a long form for them to fill out. If we can make it easily accessible to them so that they can capture their judgment while they're still in the clinical setting with the resident, then we might facilitate them completing those assessments. We think that our supervisors are already making these decisions and are already making these judgments when they're working with the residents. What we need to do is capture those judgments and decisions in a way that's as easy as possible for the supervisor. All right. So we'll just move into the next section in terms of how these milestones and entrustable professional activities will be developed. With competence by design, as I've alluded to, specialty-specific milestones and EPAs will become parts of the standards of training for each specialty and subspecialty. So they'll become part of the suite of documents that we hold at the Royal College that describes the discipline to others. And so the development of these new standards will be done by the specialty committee. And when I say the specialty committee, I mean the entire specialty committee, which includes all its program directors as well as its regional representatives, exam committee board members, and so on. And that specialty committee will be asked to think about the stages of training for that specialty or subspecialty. What would the focus be for us in our discipline? How long do we want this stage to be for our discipline? What's appropriate for us? The specialty committee will craft those milestones and will develop those entrustable professional activities. We'll use the milestones to make up a pathway of competency requirements. We'll build on the generic milestones that have been written as part of Canada's 2015 and modify, adapt, or add in the specialty-specific milestones that deal with that specialty or subspecialty's distinct knowledge and skill set. And that pathway of competency requirements will map that expected progress of a resident across time, and program directors will be able to use it to link to learning opportunities and educational activities. And as we've alluded to, the entrustable professional activities will also be linked to required training experience as well to specific assessment strategies. We want to support the specialty committees as they do their work. And at the Royal College, we've adopted a cohort rollout approach to this, meaning that we'll be working with a specific and already identified number of disciplines each year to help them through this change. I've mentioned we've already worked with medical oncology and otolaryngology. We have 6 disciplines planned for next year, and then 10 to 12 until all 68 specialties and subspecialties have switched over to competence by design. That work will be done at face-to-face workshops with the Royal College. We anticipate that each group will need at least 2 multi-day workshops and perhaps more to accomplish that task. But what about you? What can you do, and what can you do now? If your discipline isn't converting over to competence by design, what are the sorts of activities that help prepare you, your programs, your colleagues, your faculty members? So our suggestions are continuing to develop your own as well as your faculty members' understanding of competence by design concepts. We are encouraging you to think about residency training in a new way, to step back from what you've always done and think, if I was designing a system today using these concepts, what would residency look like for me? We encourage you to focus on the progression of abilities. These are ideas that we often have in the back of our mind. We rarely talk about it with our colleagues, and we may not have the same ideas of what we expect of a resident at this point in training. We're going to ask you to develop a consensus around that as we create competence by design for your discipline. So any work that you can do to help develop your own thoughts around this, to help develop consensus with your colleagues, will help you not only now as you teach and train residents, but as we ultimately design new standards for your discipline. And I'd encourage you to consider some entrustable professional activities in your clinical environment. In the clinical rotations that you normally participate in, what would be an entrustable professional activity that you would assign a resident at that particular stage in learning? I've thought about this in my own general nephrology clinic. When I get that rotating internal medicine resident, what are the things that I can really focus in on them? What's appropriate for them to learn out of my clinic? What are the tasks that I'd like to be able to shut the door and let them be able to do on their own? So I think we've reached the end of our slides. I'll pause here for any more questions. We have about another 5 to 8 minutes left, and I'll just show you a couple of links that you can follow if you'd want more information, as well as some information on how you can use this webinar to earn some Section 1 credits. I'll also remind you that the webinar audio will be posted within 2 weeks, and the slides in English and French will be posted within the same time frame.
So the first one is just a comment towards the last question about the person alpha testing the milestones. This is why we need e-portfolios soon.
Yes, and I think what we're getting that is a way, we didn't specifically talk about ePortfolio, but ePortfolio is a project that we have at the Royal College. We are developing an electronic format that residents would use to track their learning over time. It would be a format on which supervisors could access and complete assessments on their mobiles, on their computers, in their clinic, and a way that programs and program directors can help track residents' progress over time. So it's under development.
Okay, next question. I imagine there will be many similarities from specialty to specialty. Are there milestones and EPAs available that we can look at now and be inspired by?
We do anticipate that there will be some similarities. We're already identifying in our first 2 disciplines as we work with a medical subspecialty and a primary surgical specialty that there are some similarities in how they're conceptualizing and thinking about their training. So, for example, common things or common contexts, common medical and surgical patient presentations are more likely to be in a foundation phase. Urgent or emergent presentations where a resident is more likely to have to act quickly without supervision are more likely to be in a foundation than in a core phase. So we do think there will be some learnings that we can carry over. At this time, we don't have any completed sets of milestones or EPAs, but medical oncology and otolaryngology are meeting again this spring to continue with their work. They've both currently developed a draft of their milestones, but we have yet to validate and verify that draft with them, so I'm not able to share, other than specific examples, that with you. But we do anticipate that we'll have something more to show in the coming months.
Okay, next question. After successful completion of EPAs, are EPAs ever retested at a later time to ensure no decay in skills or learning?
The answer to that question, I think, is maybe. I think it depends on how the specialty or subspecialty designs their training. So some EPAs may not need to be reassessed later because, as has already been alluded to, they may actually build into more complex clinical tasks so that, in effect, you're already observing them again as part of a more complex, bigger task at a later stage. Some of them you may want to circle back to, that idea of a spiral curriculum where something is learned and assessed and then yet learned and assessed again. And so that, again, will be an educational design decision that we take with the specialty committee.
Okay, next question. What do you see as the role of continued coaching even after a resident has achieved an EPA? We can always get better.
Absolutely, and I didn't focus on it, but on the earlier slide about curriculum and assessment, where we had that nice curve of competence moving on to proficiency, moving on to mastery, I think it really illustrates that although we can set a level of expectations, we can always do better. And I think that coaching does exist, and the concept is not to stop any further feedback once an entrustable professional activity has been achieved. There will be milestones that are in the next stage that supervisor can use to help encourage further learning along that continuum of progression. There will be milestones that are written for physicians in practice so that even a resident at a senior level can start to see what the next level of performance would be so they can continue to progress.
Next question. How can we find out when our specialty will be moving to competency-based education with the Royal College?
A draft plan exists for all 68 specialties and subspecialties. It has been shared with the postgrad deans and it's been shared with the specialty committees. That was done last November. I believe it is part of the information that's available on the Royal College website in the CanMeds and Competence by Design section. So thank you very much. I hope that's been a fruitful and informational hour. If you do have any additional questions or if there are questions that we weren't able to get to within the hour of our session, we have been tracking them and we will be emailing the answers to the submitter over the next few days.